A child can go from noisy breathing to crashing fast. And one big reason is this. The pediatric airway is not just a smaller adult airway. In this episode of TSN 5, I want to give you some tips and tricks to help navigate your next pediatric airway, but also help you understand why these airways are so much more challenging. So let's get right to it. What makes these airways different? First of all, the airway diameter is tiny. That means that even a small amount of swelling, a little bit of mucus, a little poor positioning can actually cause a pretty significant problem. In fact, just 1 millimeter of circumferential edema in an infant airway can actually reduce your cross-sectional area by about 50 to 75% and create about a 16-fold increase in airway resistance. That's a huge physiological penalty. Secondly, the tongue is proportionally larger in these kids, so any loss of tone can cause pretty rapid airway obstruction. The larynx in these pediatric patients is actually much higher and more anterior. So we're typically looking at the C3 to C4 level in children, whereas in adults, it's at the C6 level, and that can potentially make visualization of structures much more challenging. Third, the epiglottis in these kids is often longer, floppier, and omega shaped. And that's potentially where our straight blades can help us try to lift that epiglottis out the way so we can visualize the anatomy to the best of our ability. Fourth, these infants tend to be primarily nasal breathers. So what that means is any significant nasal congestion, secretions, upper airway swelling can actually produce a lot more distress very quickly and much faster than you might anticipate. Lastly, the trachea in these kids is actually much shorter. So after intubation, tiny movements matter. That means that if you're a little too deep, you're going to be right main stabbed. If you're a little too shallow and you're trying to secure that tube, you might accidentally extubate them. So having established all this, what can we change for our next airway? Number one, positioning. These kids have larger occipits. Laying them flat, trying to flex their neck is actually going to worsen the airway. So this is where a shoulder roll might help you get them into more proper alignment and set you up for success. Number two, suction. Try to get as much of the secretions and blood out of the airway as fast as possible, because if you don't, that airway can get lost very, very quickly. And that leads me to my next point. Oxygenate early and aggressively. These kids have very, very low functional residual capacities and they will desaturate fast. So pre-oxygenation is so key. Lastly, size everything correctly. Make sure you have the right size tube, but also one size smaller. And the same goes for the blades. A couple of key tips that I've always remembered is if you have a newborn, Miller 0. If you have a 1-year-old, a Miller 1. If you have a 2-year-old, I want a Miller 2. If you have somebody at the grade 3, that's around 8 years, I'm thinking about a Miller 3. And lastly, make sure you always have a backup, because each repeated attempt is only going to make the next attempt much more harder as that edema sets in. So bottom line is this. Tiny airway, tiny margin for error. Respect the anatomy, optimize positioning, treat edema and obstruction like the threats they are, and you'll be able to manage your next pediatric airway much more safely.